Alterations in integument. Burns. Burns are tissue injuries that are caused by heat, chemicals, or electricity. The severity of the burn is determined by the temperature of the heat source, the duration of the contact, the thickness of the tissue that is exposed, and the burn location. Thermal injuries, in other words, those caused by heat, cause coagulation of proteins in the cells. And chemical injuries actually liquefy tissue and loosen cell attachment, while electrical injuries cause damage to the tissues or organs from the entry point to the exit point. With an electrical injury, you're always going to have the place that it enters the body, and it can travel all throughout the entire body, and then it will always come out somewhere. So always find the exit point when you have an electrical injury. We may also see cardiac dysrhythmias with electrical injuries and central nervous system complications. An inflammatory response can extend the initial burn injury and cause ischemia and tissue necrosis. The most serious burns can cause a hypermetabolic state. This is increasing the client's need for oxygen and nutrition. With burns, the fluid is going to shift, and electrolyte disturbances can occur when those fluids move to the burn, causing an intravascular loss and fluid loss from the burn. Anemia, renal failure, gastric ulcers, and inhalations can also occur with a burn. True or false? Burns can affect fluid balance. This is true. Burn depth is assessed from the color, skin characteristics, and sensation of the burn injury. A superficial or first-degree burn is going to be very similar to a sunburn. So it's just going to involve the very top layers of the skin, although we may see some blistering with it. A superficial partial thickness burn is not going to cause scarring. A deep partial thickness burn may cause scarring, and it may also require debridement or skin grafts. We would consider that a second degree. They're going to be dependent on the amount of the dermis that is burned. Pain will be significant with superficial partial thickness burns. They can also be very significant with superficial burns because the nerves are involved. However, with full thickness burns, this is destroying all layers of the skin and is painless because it has also destroyed the nerves. The skin is charred. It may have a white, dry, leathery appearance to it, and it will require debridement. Fourth-degree burns not only involve the nerves, it burns the nerves, it's also going to burn the ligaments or the tendons or the muscles and the bones, depending on the location of that burn itself. The extent of the burn injury is going to be determined by a couple of different methods. Understand that in this course we're talking adults from the age 18 to the age of 65. If we're talking prior to the age of 18, those are considered pediatrics. If we're talking after the age of 65, those are older adults. Pediatrics have a different model that is used because of the difference in the size of the head compared to the torso, etc. So this is specifically about the adult patient. There is a quick initial method of estimating how much of the client's skin surface is involved by looking at the client's palm. We compare that with the size of the burn. The palm is approximately 1% of the person's total body surface. We can do another quick initial method of estimating how much of the client's skin surface is involved by using what we call the rule of nines, in which areas of the body surface are assigned multiples of 9, and that's what you see in the slide. Now understand, we're looking at, let's say, the right arm. The front of the arm is 4.5. The back of the arm is 4.5. If it's the entire arm, then that would be a 9, and so on and so forth. And then we have the Lund and Browder method. It's going to be the most accurate, and this is the one that will be used by your burn units especially, but it can be a little bit more involved and a little more difficult to use in an emergent situation. True or false? A burn severity is affected by the temperature of the heat. And this is true. There are some life-threatening complications that can occur with burns. One of these is inhalation injury. We should always suspect inhalation injury when the client complains of a sore throat, they have singed nasal or facial hairs such as the eyebrows or eyelashes, beard or mustache if they have those. When they talk, they're very hoarse. They may cough and cough up sputum that has carbon in it or dark splotches. There may be edema of the face and neck, or we see soot, that dark powdery substance around the mouth or the nose, shortness of breath, or stridor. Stridor would be caused by swelling of the throat, where we only have a very small area for air to get in and out. And it sounds something like this, where they can't get good air movement to the lungs. We also suspect inhalation injuries if burns occur to the face, the neck, or the upper chest. Always consider in those instances that inhalation injury is a possibility, or if they were in a burning building for an extended period of time. Inhalation injury is often associated with swelling of that airway, inhalation of carbon monoxide, and ultimately respiratory failure if that client was there for an extended period of time or they were really close to the source of the fire. And it may require mechanical ventilation. Other life-threatening complications include hypovolemic shock, especially if there's a large area of the body that's burned and they've lost a lot of fluids, and infection. True or false? An infection within a burn wound can be life-threatening, and that is true. So how do we treat burns? Initial first aid. Our first priority is to prevent further injury. So we have to stop the burn. This means that we're going to smother that fire. We're going to remove any objects that are burning And this will include potentially metal jewelry that the client may be wearing. Remember, those are going to retain heat for a longer time and continue to burn. Then we need to observe for any respiratory difficulty. So primary is going to be managing the airway. Don't forget your ABCs. Then administer oxygen and provide IV fluids as soon as possible. With the acute care, this is once we've initiated all of that initial first aid, we need to begin to assess the extent of the burn injury and any additional trauma. We continue with oxygen and/or mechanical ventilation. We are doing the fluid resuscitation, and this is based on what we call a Parkland formula, where we consider the client's weight and the total body surface area that's burned to determine the amount of fluids that we're replacing. They may require a bronchoscopy, where we go down the airway with a tube to determine any damage that may have been done. A tracheostomy, where we cut a hole into the trachea at the base of the throat to provide an alternate airway. They may require hyperbaric oxygen treatment, analgesics, and burns require tetanus immunizations. Anytime we have an open wound, and this includes burns, we always ask the client, when was your last tetanus vaccine? Tetanus should be administered at least every 10 years. In a dirty wound, it may be administered as often as every 5 years. And then we need to do wound management. So again, removing that clothing as soon as possible, we would clip or shave our hair in that area, cleanse the mouth and the lips, irrigate their eyes, cleanse the wounds, apply topical antimicrobials. There are a couple of different ways that we can treat burns. One of those is the open method, where it exposes the wound to the area. It requires isolation of the client to help keep the client from getting an infection. And we need to keep the room very warm and humidified. It will also require debridement to remove crusts or eschar. It may also require an eschorotomy, where we create incisions into eschar. If we have a large burned area, the tissue will no longer stretch to accommodate swelling. So they basically just make an incision in the wound, in the burn, that eschar, to allow for swelling. And it may require multiple incisions. If we don't do this, then it can begin to constrict the area, and then it will impair circulation. A closed method is going to be application of dressings with antimicrobials. One of the antimicrobials that we use would be a sulfonamide. In burns, we call this, if it's a topical, we call it silver sulfadiazine. Basically, our sulfonamides are a broad spectrum antibacterial medication, so it's going to kill a large number of microorganisms, and it's often combined with trimethoprim, especially when we're treating UTIs. These are also good for treating respiratory tract infections, opportunistic infections, etc. Contraindicated in clients with drug allergies to sulfa. We should never administer a sulfa drug to a pregnant woman at term or infants younger than 2 months. Allergic reactions occur with almost every kind of antibiotic. So this is going to be the main adverse reaction. So be very aware of potential hypersensitive reactions. It can also cause photosensitivity, which is going to be sensitivity to light, and then it could potentially cause GI, liver, kidney, or blood complications. If a client is a diabetic and type 2 diabetic that is taking the oral anti-diabetic medications, they can actually have a reaction to a sulfonamide because it's going to increase the hypoglycemic effects of that medication. It can also cause toxic effects of some other medications. Clients taking sulfonamides should always increase their fluids because the risk of crystallization in the urine is really strong. So we increase the fluids to prevent that from happening. And again, always use a sterile glove when we're applying this ointment, this cream, to a burn. There is also a topical antibacterial called nitrofurazone, which could also be used for a burn. And adverse effects include erythema, pruritus, dermatitis, a rash, edema, or inflammation. Do not use it on large burns where we have a large total body surface area that has been involved. This medication, trade name might be Furacin. In addition to the treatments we just discussed, there are other treatments to promote healing that include debridement, so removal of that dead tissue. We might apply a skin substitute or skin grafting. Debridement, again, is removal of that necrotic tissue. It can be done naturally, mechanically, with enzymes, or with surgery. Disadvantage to this type of treatment is bleeding. A skin substitute is basically a temporary covering. Skin grafting is going to cover large areas of burned tissues. It's going to lessen the risk of infection, minimize fluid loss, also helps with pain, encourages tissue regeneration, reduces scarring, and can prevent function loss. We may see hypertrophic scarring in a large wound when skin substitutes or skin grafting are not used. In other words, we have a lot of scarring, heavy scarring, if we don't use skin substitutes or skin grafts. Sources for skin grafts usually will come from the client's, or often will come from the client's own skin. We call this an autograft. It is basically the removal of a small area of skin. We can culture it and then transfer it to the burned area. We can do a split thickness, a full thickness. A slit graft will allow a graft to cover more area with a smaller piece of skin. Disadvantage, there's more pain from a new wound. We also have scarring from that donor site and a risk of infection from the donor site. There might be a delay of wound closure and, of course, increased medical cost. An allograft would be skin from a cadaver. A heterograft is animal skin that might be used. And then we might use a pressure garment to also help reduce scarring and wound contractures. Silicone therapy is considered to be the gold standard to burn scar management. It reduces redness, it flattens raised scar tissue, and improves elasticity. And this can also be used with pressure garments. When we are assessing the client, we also need to assess the client's psychosocial status and not just focus on the wound. We need to do that calculation infusion of the fluid replacement requirements. Again, this is not necessarily something the LPN is going to do, but the LPN can help monitor the client while receiving fluid resuscitation. We're also going to be monitoring for signs of shock and helping implement treatment of shock and definitely taking care of pain management. LPNs can do wound care, application of antimicrobials, dressings, monitoring for infection, and providing emotional support. And LPNs can reinforce client teaching, doing exercises to minimize contractures, taking in adequate nutrition, wearing of the pressure garments, skin care measures, and the use of sunscreen, especially on this scar tissue. And your post-test.